Hi students, this is Dr. Penrod, and I'm going to get started with the PowerPoints for NUR 320. Your first chapter that we're going to look at for class is Chapter 2, Obtaining a Health History. So this is out of your textbook by Wilson and Giddens, 7th edition, Health Assessment for Nursing Practice. So we're going to go ahead and get started. So the first step that you have to take to get, to be able to make an informed physical assessment is to gather a health history on your patient. So we're going to go ahead and move on. So it's important to consider your physical setting. The setting that you get the health information from your patient. It needs to be private, it needs to be quiet, comfortable, minimal distractions, in a situation where you both can sit face to face. So it can't be overemphasized the importance of privacy, because you're not going to get the same information from someone who fears for their privacy. So just make sure you consider that. Any situations dealing with the physical setting where they may or may not disclose complete information. So we can ask questions about drug abuse, sexual activity, things that they might not want to disclose in front of different people in the room. So privacy is best gained by conducting your interview in an unoccupied room. And some people, they prefer to have family members beside them. You might offer, are you okay with doing your health history with your family present, or would you like for me to come back another time when we can speak privately? And just kind of move on from there. So another thing to consider too is the patient needs to be physically comfortable during the interview. So make sure that, if the patient needs to use the restroom, if they need water, you just want to keep the anxiety level down, and the need for other things to help with are minimized. So make sure also that the amount of space between you and the patient fits the patient's culture, because some cultures, they actually become more anxious the closer in proximity the nurse is to them. So just keep that in mind, and making sure that you conduct the interview in a quiet setting. So there are different phases of the interview. You're going to first introduce yourself. You're going to get into a discussion with them about different topics, and then you're going to summarize. And a lot of the interview is the art of asking questions. And you may remember from Nursing 300, we touched on this a little bit with you, the different questioning techniques that you can use to help bring out information out of your patient. So I'm going to go ahead and move on to the next slide. So like I said, types of interview questioning and techniques. So and as you talk to, as you look through this textbook, it starts talking about the phases of the interview. That's on page 10. And then the art of asking questions. So it starts on page 11 and actually talks about all these different types of interview questions and techniques that help enhance your interview. So I have them listed on the slide. Utilizing active listening. It means listening with a purpose and noticing nonverbal behavior, trying to concentrate on what the patient is saying, and conveying with what the message is being conveyed by facial expressions, body language. So just taking all of that into account, you're trying to predict. You want to make sure and stay away from trying to predict what the patient's going to say, and when you're trying to formulate your next question, it needs to totally be a back and forth type thing. That you are talking, the patient is listening, and then you listen while the patient talks and take in all the different cues that surround what the patient's saying to you. So facilitation is it's a technique that you use that encourages the patient to continue, like go on, then what, question mark. So, and then any nonverbal responses, like head nodding, shifting forward in your seat. All those things help facilitate discussion. Clarification is another technique. That's, when you ask a question, the patient might say, I could use this example here in the book. I was so hungry, I almost lost it. And the nurse might ask for clarification. What do you mean by you almost lost it? Or, the patient says, I just wasn't able to return to work. And then the nurse might say, well, what do you think kept you from returning to work? So you're just clarifying what they're saying. Reflection is a technique where you literally reflect what it was that they're saying. So the patient says, I got out of bed and I just didn't feel right. The nurse says, you didn't feel right? So they're just reflecting what the patient is saying. And when they reflect, then just naturally the patient will clarify what they meant by their previous statement. Confrontation is used when you're getting inconsistent information, or you're getting information that comes from what the patient is saying to you, then observations or what the chart maybe says about the patient. So you might say, they might say, well, I ate all my supper last night, and then they might have reported in the chart to the CNA earlier, that they just took like a half a bite of their hamburger. And so then you need to ask them and say, I noticed, like you mentioned, say, I'm confused. You mentioned that you ate all of your food, but then you told the CNA that you only ate a couple of bites of your hamburger. So can you help me understand this? So you don't want to be the word itself, like just in day-to-day life, when you're confronting someone, it sounds very offensive. But you have to, a confrontation doesn't have to be offensive. It's just like a clarification. Like you're saying, I see this, but then I see this. Can you help me understand? That kind of thing. Okay, an interpretation is when you are like reading through data that was given to you, and you're asking the patient to help you interpret it. So you say, let me share my thoughts about what you've just told me. So you're interpreting what they're saying to you, and then they answer you, and they tell you if you were right or wrong, or they might clarify. So that's a questioning technique where you take what they've said to you, you say, this is what I hear you saying, blah, blah, blah. And they say, yes, that's right, that's what I'm saying. That's interpretation. And then summarizing is literally when you're taking all the data that they've given you, all the information, and then you're kind of summarizing it. So you might take their whole health history, and you might say, okay, so the key things that are the key surgeries that you've reported to me. You've had heart surgery and you've had neck surgery. And you're kind of summarizing all of their surgeries and saying these, I think, are, or you talk about like someone fell off of a ladder at home. You might state, this is what I hear you saying, and you're interpreting the story that they've told you. That would be interpretation. But then at the end of your interview, you might go through and summarize the interview and all the data that you've gotten from the patient. Okay, so that is the art of listening. And the next slide is behaviors that interfere in an interview. Using too much medical terminology, being judgmental, expressing value judgments, being authoritarian and paternalistic. We definitely don't want to do this, especially with older people. We tend to, or it could be anyone, but I see this a lot with working with the elderly. Like sometimes we might talk like we are the adult and they're the child. We definitely don't want to do that, especially with an adult who has lived a life of independence. You definitely don't want to slide into, they're there, honey, that's okay, and being paternalistic with them. And sometimes we use names like honey, sweetheart, baby, or that kind of thing, and that is interpreted as being very, talking over the patient or being paternalistic or authoritarian. So using why questions, why doesn't ever really help nurses too much. So, if the patient fell off of a ladder onto the ground, you're not going to say, well, why did you get up on the ladder? Or why didn't you have someone hold the ladder? Or why did this happen to you? Or why were you there? Those things aren't helpful. The why, we want to, the things that are helpful is understanding how something happened rather than the why. Okay. And awkward moments is you're going to have as a nurse when you're asking personal questions. It can be challenging. Sometimes silence is very helpful, but some people are not comfortable with silence. Silence actually can be a tool for you, because the period of silence where you let the patient think for a little bit, you may actually glean more information from that moment. So sometimes we can fill the air with so many words that the patient doesn't really get a chance to share what's really relevant. Displays of emotion, like if your patient starts crying, starts yelling, these things can be challenging for a nurse to get information. It definitely does not help to tell your patient, don't cry, don't do this. You need to say, crying is a natural response to what's happening to you. I'd like to give you some time. And give them some time to kind of regroup their mind and get focused back again. The book says, take all the time you need to express your feelings. And you can just postpone what you're asking them until they're ready. So if they start crying over a situation, then say, hey, I'm going to go check on another patient. I'll be back in a little bit and we can continue. I'm going to give you a chance to relax for a little bit and I'll be back. And be positive about it. Don't make the patient feel like that they have put you out because they're being emotional. An overly talkative patient, boy, this can be a challenging situation. Some patients love to talk. They do. And for some patients, just being around people in the hospital, they haven't had that much interaction in days, maybe weeks. So just having an audience or someone to talk to is really a big event for them. So, but sometimes we have to try to steer them, the talkative patient, we have to steer the conversation to things that are therapeutic for them, information that we need to know. So, some cases you might need to redirect the patient, but you just have to do it in a very subtle way so they don't pick up on the fact that, you really don't need to hear everything that they're sharing with you. So another challenging situation is when there are others in the room. I've had situations where I've interviewed a patient and I can tell, well, a really good example is when I've interviewed, let's say I have a husband and wife in the room, and the husband is the patient, and the wife tries to answer all the questions for him. What I'm wanting to do is I'm wanting to find out what he knows about the situation. I'm checking out his orientation and how much he understands about the situation. And sometimes having that other family member who is trying to help the patient or cover for the patient, sometimes you can't get an accurate assessment when you have that kind of situation going on. So you might politely ask if that person could leave the room so you could talk to the patient privately. Definitely if it's a child, then you have to kind of work with that situation. But if a child is suffering from abuse, they're not going to be honest about it in front of a family member. Patients may be unable to answer questions for themselves, and they may need that other person to answer the questions. So we have to be able to discern how much our patient really understands in a situation like that, and try not to offend the person who seems to be answering all the questions. It's just difficult. But as you gain more experience as a nurse, you learn how to navigate these situations. And then disruptive individuals. Sometimes you'll either have the patient or you'll have a family member that becomes disruptive. And that can be very challenging to get the information you need. Like, let's say a family member has been admitted to the hospital. Well, the person visiting may be hot and mad because that person was admitted. Like it was some kind of interruption in their day, and they become disruptive about it, or they don't like the diagnosis that the patient has, so they become disruptive about the diagnosis or how the patient's being treated right now. So those are difficult situations, and if a person is disruptive and it's interfering in the care of the patient, then you may have to politely ask that person to leave. And if that person is so disruptive, then you may have to call your charge nurse, and then it escalates. If they escalate behavior, then your charge nurse may have to call security, and the person may have to be literally walked out the hospital. It does happen occasionally. So disruptions, they create a distraction. You can't get done what you need to do. There are some disruptions that aren't angry people, but it may be children. Maybe children just bouncing off the walls in the patient's room, and you may need to ask if someone could watch the children while you attend to the patient. So it's really all about how well you're able to do what you need to do with the patient and get the information that you need there. Okay, the purpose of getting a health history. Like I said, you may remember from last semester that when we do an assessment, we collect subjective data, which is the health history, and we put with that any objective data we have. And objective data is what we observe, or verbal, nonverbal behavior that we observe, or parts of our physical assessment. So we put together the subjective data, the objective data from our physical exam, any labs or x-rays that we may have, and that is everything that goes into the patient's database, their EHR, or electronic health record. So when we put all of these pieces together, we get a complete picture of the patient's past and present health status. It's a really great screening tool. So we listen to what the patient has to say. We look at the labs. We do our own physical assessment. And we get a really good idea of any abnormalities going on with our patient. So our assessment and the health history, all of it, is printed in electronic format, and it's available for other disciplines to read. It can be reviewed, it can be validated, it can be updated. So We do different types of health histories. We might do a complete health history. That's when we might be admitting a patient for the first time into the hospital, or we may do just a quick health history, depending on a focused complaint that the patient has. And when we use the word complaint, we're not saying the patient is complaining about stuff. We're saying what the main thing is that the patient is saying is wrong. Okay, physiologically wrong. So the nature of the complaint may be the nursing diagnosis they have that's admitted them to the hospital. Okay. So there are different types of health histories. Like I said, there's a comprehensive health history. There's a problem-based one where we focus in on a particular problem as part of the assessment. And then we also can do episodic or follow-up health histories as part of our assessment. That might be something that we might do, like we work day shift one day, and then we might be off for a day, and then we might have that same patient the next day. Well, we might do a health history, like we remember the information we gathered earlier or 2 days ago, but we might be doing a follow-up on how things are going and if anything new has happened with the patient. So that's an episodic or a follow-up health history. So the health history, we do it in this sequence. We start with biographical data. Your biographical data are, the things such as age, culture, gender identity, language, their reason for seeking care. Biographical data is height, weight, those kind of things. Where do they live? What type of work do they do? Reason for seeking care. What brought you in to see the physician today? Or what brought you to the ER today? Their present health or history of present illness, their past health, and then we get into their past history and then their family history. There are many disorders that have a genetic component. So if I have a family member who had diabetes, that's valuable to the nurse to know. They might, if I'm displaying symptoms of diabetes, then they might want to run some tests to see, how I'm doing with blood sugar control. So that family history is important. Any personal or psychosocial history. So you might just kind of get an idea of what, the patient's married, if the patient has children, what type of job do they do. You get a sense for how they talk, how they feel about their life so far. So, those kind of things. So, and then we get into a review of systems. We ask different questions, pointed questions related to the different systems of the body. And then after we do that, then we go into a functional assessment. One of the most important things that we can do with our health assessment is to assess activities of daily living. Because if a person, we want to assess, is the patient able to get up and down to the bathroom? And if they're having difficulty with that, we need to make note of that, because maybe while they're in the hospital, they can get some physical therapy or occupational therapy. Anything we can do to help the patient lead a more healthy life at home, we should attempt to do if possible. So, when we do that functional assessment, how's your appetite? Are you able to get up and down? Are you able to take care of your own, toileting? Those kind of things. Because we can help with referrals. And it helps the nurses to take care of patients better. So the health history, areas of focus that may differ slightly in terms of what the individual patient's concerns are. their learning level, like some patients, like if they have a cognitive impairment, your focus may differ slightly. The culture of the patient, just kind of keep in mind different cultural groups. We may focus on different things according to the patient's culture. The age of the patient. Actually, this is talked about on page 9. So, in regard to culture, we want to make sure I think the main thing with culture, because we have to be careful not to stereotype either, is for us to remember that everybody is an individual. So we need to make sure and address the patient's needs according to what they believe their needs are. So there's even so much diversity within a cultural group that we just need to be mindful that everybody is individual and they may display different values. So just being mindful of that is important. Age of the patient, adults, adolescents, they may be able to participate in the interview. Children they may not be able to participate. You may have a parent or a guardian helping. And then older adults, sometimes they require accommodations with their health history. Gender identity and expression, just make sure that that you address that when you're assessing a patient. And the book goes into some different definitions in case you're not familiar with what cisgender, transgender, non-binary, and agender means. And then, of course, language is going to be important when you're getting a health history. So make sure that you are understood by the patient. If you think that there is a language barrier, you may end up needing to get an interpreter for the patient. And then also sensory impairment. That's a big part of your assessment is your patient's ability to hear and to see. So when you have someone with sensory impairment, it does make the interview a little more challenging. So if a person's hearing impaired, you may have to speak slower and clearly. Make sure you face the patient. Just hold your interview in a quiet room so the patient can focus in. And you might need assistance in helping an individual. You may have to assist an individual with completing their written interview. Okay, and the rest of these slides just break down the pieces of the components of an assessment. And I'm getting close to the 30-minute mark, and I know you guys may not particularly pay attention after this. So just make sure you review the different components of biographical data. So all of that gets started on page 15, bottom of 14, going into 15, talks about the components of a health history. So then it breaks down biographical data, reason for seeking care, and I think these slides are pretty self-explanatory. So just kind of follow along with these slides, and you need to mark down like who is giving you the health history, and make sure that person, if there is another person who is providing information, is that person reliable? Are they able to communicate, and do you need an interpreter? So you need to make sure that whoever it is, if it's the patient or if it's a family member, make sure that they're reliable, they can communicate, and make sure that if you need an interpreter that you get one. Reason for seeking care. Some different things on this slide for you to consider with this. Present history, health and history of illness. So so it goes into current health conditions, medications, allergies, past health history. This is an acronym that helps you go through a symptom analysis. So the onset of the symptom, the location. So if we looked at pain, pain is a symptom. So these are the characteristics that you want to know. When was the onset of the pain? Where is the pain located? How long has it gone on? Or how long does it last? What are the characteristics of the pain? Such as, is it stabbing? Is it numbing? Is it a dull ache? What are those characteristics? What aggravates it? What makes it better? What makes it worse? Any related factors along with the pain. Like, let's say that you're having acid reflux and you're having burning in your throat. Well, that happens when you eat food. There's a related factor to that. Treatment, what helps alleviate the pain? And then we ask them to rank their pain on a scale, 0 to 10. So OLD CARTS is an acronym that helps you run through the different pieces of a symptom assessment. Now, another one that this book does not talk about that's very handy, and you'll see it in other textbooks, is PQRST. So the P is pain, Q is the quality of the pain, R is does it radiate, what relieves the pain, S is any other symptoms that go along with it, T is the timing of the pain, and U is your understanding of what's going on and how it's affecting you. So that's another acronym that you'll see in other textbooks is PQRST. Oh, I have it right here. So P is provocative or palliative. That's what makes it worse, makes it better. Q is quality. R is where the region, where the location is, or does it radiate. S is severity. T is timing. And U is your understanding of the perception of the problem. So I didn't realize it. I had it right here. Okay, and then here are a couple of questions that relate to this chapter. So I think this winds up the rest of this PowerPoint. There's a few more slides on past medical history that you'll want to look at, review. They're very self-explanatory, so I'm going to go ahead and let you look at those on your own. And family history, personal and social history, and additional questions for new immigrants. You might ask, biographical data, any restrictions related to their spirituality or religion. So you want to make sure and address that, because even like dietary, there are dietary restrictions depending on a patient's culture. Any past health immunizations. Other countries may or may not be up on immunizations. They may not have, state-mandated immunizations. So we've got to make sure and go through that with our patients who are immigrants. Their health perception. How would they describe their health or illness? How do they see the problems they have now? And any restrictions as far as nutrition. So then you go through a review of systems in a head-to-toe motion. And the book goes into that when you start with, on the bottom of page 18, it goes through system by system, different questions that we would ask the patient. Okay, I think that's about it. That's our system approach. All right, and functional assessment I mentioned earlier. That we look at their ADL status, their ability to take care of themselves, and any relevant data related to lifestyle. Okay. All right, so I'm going to go ahead and scroll right on through. I'll give you an actual copy of this PowerPoint so you can look at it on your own without the audio over it. So I will see you soon. Thank you.